I'm grateful to be invited by the committee and thank them and Keld and Pippa and all the patient organisations and Jeanette, who's done so much of the organisation. I was asked to talk about what we've learned from our Digital Respiratory Health Summit, and it was great that you took part too, and there was some fantastic presentations on the management of digital exclusion and also on the use of real world data. What I will do is just move forward if I can. There we go. So what we focused on in the summit was realism versus futurism. So what digital resources are we using now? What are we likely to use in the future, and what's the pathway between those two? And for this morning's purpose, we'll focus on digital acceleration with respect to remote consultations, how we can do those better perhaps, the virtual world, so virtual wards and virtual rehabilitation, touch on wearables and apps, because I'm sure you'll be coming back to them, and then the thorny issue of the appropriate use of artificial intelligence and the ethics surrounding that, and then end with where we might be going next. So there has been a lot of publicity, and some of it adverse, around remote consultations, and Keld mentioned his remote consultations. I'm sure you may well have been involved in them. I think we all have. And this is something that has been happening for a while, but the amount of acceleration, and this is looking at remote consultations, you can see this is around March to April in 2020. So a huge acceleration with the onset of the pandemic. So a huge increase in remote consultations and a decrease in face-to-face visits for very obvious reasons. So numerically, this was a vast change. But as we all know, the consultations are not exactly the same. And this is just showing you some consequences, the differences in the consultations from face-to-face to telephone or telemedicine. And that is, for example, the number of follow-up appointments that are made after a teleconsult are greater than a face-to-face contact. And the number of patients that are discharged from follow-up are less from remote consultation, suggesting that there is an issue with getting the information and making firm decisions, perhaps related to the nature of the contact. And this was explored during our summit by Professor Hilary Pinnock. She is a professor of primary care medicine, but she's also a GP in a practice in Kent in the UK. And she summarized some of the evidence around how these consultations differ. And there's quite a bit of evidence to show that the nature of the consultation changes. So there's less basic data gathering, as you can see here, somewhat less of education and counselling. And for obvious reasons, whether you're on the phone to your healthcare provider or whether you're doing a video consultation, there can be less building of rapport than when you see someone face to face, you touch them, you examine their chest. On the other hand, there are a few advantages. I've met many patients' pets during video consultations and have been pleased to do so. Also, other subtle differences, less direction giving, it was found in this study by McKinstry et al. And very fundamental differences in this study here, showing there was less time for consultation during the remote visit compared to face-to-face visits. Now, this is clearly very important, and also a tendency for less problems to be presented during remote consultation. So far more likely to be one major problem than a range of different problems. And there are very likely to be consequences to that. Hilary suggested really for healthcare practitioners to ensure that they enabled patients to get the best from the consultation. And so there are a range of templates around, some of them really very obvious in their content, but really stressing for all healthcare professionals that the first thing very obviously to establish is, what do we want to get from this consultation? What are the key areas to discuss? Is there one area or the several areas? And then, and this is an example for asthma, to understand the control of the asthma and various factors that might be related to attacks, treatment options, treatment, self-management plan. That's pretty straightforward. You do in both types of consultation, but it's important that none of this is missed out. Now, just to move from those remote consultations, I'm very happy to discuss this subsequently to other areas such as the virtual ward. This too showed a huge leap forward, although we've had virtual wards in the past. So this is you being managed in your home, but having a supportive network thrown around you so you can be monitored at home. You can provide information via telemonitoring, you can have telephone support, and you can have quite intensive monitoring, including oximetry, symptom control, and also treatments delivered at home. And I've just put an example of these were carried out and are still being carried out during the waves of COVID across member states, across Europe, and further afield. And this is one of the good examples from France, the COVID-ON project. And this just discusses the two basic really routes that you would enter a virtual ward. You could come via your GP, and that is your primary care team are basically supervising you at home. They want you to have a higher level of monitoring, but you're diagnosed in the community. And really the aim of this virtual ward is to have a higher level of attention, but to see if admission can be prevented. So to help perhaps stop you having to go into hospital and provide a number of supported treatments. On the other hand, there is a virtual ward that is provided from the hospital, and this is usually on the basis that you've been seen in an A&E department or you've been in for an admission in a discharge home. So it's to facilitate perhaps early discharge, and again, the individual is monitored at home, but there's the ability, often in both services, to provide continuing treatments such as dexamethasone. This is low molecular weight heparin for anticoagulation, perhaps oxygen treatment. And so these are the basic types of virtual ward. And then here we can see a kind of flow pathway of what happens. And some of you may have been involved in these processes, but to make the point clearly, if this is relevant to COVID, it's very relevant to all sorts of other respiratory situations. So we can use the principles learned and a lot of the monitoring that's been put in place during COVID to continue and spread this so we can manage acute exacerbations of COPD or of asthma, bronchiectasis, pneumonia, any kind of exacerbation, infections in people with pulmonary fibrosis, problems with management of sleep apnea and so on. All these individuals can be identified as suitable for the virtual ward and then onboarded into the telehealth system. So that may be oximetry, it may be spirometry monitoring, it may be daily monitoring that you record of your symptoms. So this monitoring takes place, but what one also has to set is very clear-cut escalation thresholds so that if that individual deteriorates in any way, urgent escalation to admission to hospital can be carried out, or some other intervention such as a home visit can be carried out, or by the same token, if the individual is improving, they can be discharged from the virtual ward and then continue with primary care follow-up. So I think this is exciting because we're taking the learning from COVID and immediately we're taking it forward, and it's very, very suitable for individuals with respiratory problems. Just to briefly mention pulmonary rehabilitation, very difficult to do face-to-face pulmonary rehabilitation for patients to come up to hospital gyms or even go to other gyms as they were closed. And so a lot of work and trials have been done on tele-rehabilitation with some supervision. So a little bit like now we're in a Zoom group, but you're actually doing your rehab, you're on your exercise bike at home, you're lifting your jam jars at home, and you're doing it with other people. And this study quite nicely showed, so a symptom score and exercise measurements here in steps and 6-minute walk, that there was no difference between the face-to-face or the tele-rehabilitation. It's important to say that both in this trial, both of the rehabilitation tactics didn't produce huge improvements, but I think that may be something that one can work on. And there is no evidence so far that people do worse on the tele-rehabilitation delivery of pulmonary rehabilitation. And what it's also being used as, and that the results here are not coming in, but of course there is a substantial proportion of patients who've had COVID. They're either post-COVID because they've had a serious episode, they've been in hospital and they're recovering, or they have long COVID, and obviously there are overlaps between these situations. But for a proportion of those patients, rehabilitation is helpful. And this is part of the FOSS COVID study, looking at people with long COVID and identifying the subgroup who benefit from pulmonary rehabilitation, and then making sure that that can be done. But, you know, one notices here the waiting list for those people. And so there's a lot of work to be done to develop these services. And we still don't have good outcome data yet. And hopefully they will come through soon. So to move on swiftly, during our summit, Professor Aliverti presented a nice overview of the huge panoply of apps that are available now, from the kind of monitoring that you can have during lab tests right through to wearable devices, Apple Watches, Fitbits, all sorts of other wearables, and then the ones that can look at activity, measure breathing activity, measure cough, for example, through to implantables and even ingestible devices. And the difficulty we have here is, of course, the regulation, because these are coming through the whole time, and the appropriate assessment of these, which we'll come back to. The other big issue, and I've just shown here, sleep monitoring apps, which we pretty much all have in our mobile phones. This is gathering data, remote data from patients who are on respiratory equipment at home, such as ventilators or CPAP machines for sleep apnea, that we can see immediately and help individuals if they're not getting optimal delivery of ventilation. But this nice review points out some of the difficulties that we have in incorporating this data into the individual's electronic health record, so that it can be shared with all healthcare providers, so the patient themselves, the healthcare providers, makes best use of this information. And here I think we have quite a number of barriers to ensure that all of this is included in the care pathway of the patient. Another really good advantage of the digital approach, though, was presented by Dr. Wiesenbeck, and she showed how we can make great strides forward in research. And I know that many of you may have been involved in research trials, and facilitate more recruitment of individuals into research trials, because we know one of the big barriers, difficulties with these is actually having to go up to hospital for the frequent assessments that are required. But with home monitoring of symptoms, of oximetry, of pulmonary function, of a whole number of other measures, then one can get really speedy results from trials at less impact for the patient themselves. And so this is a huge breakthrough, and I think is likely to improve recruitment, and therefore improve the speed of studies and the outcome of studies. And here's one trial that was done with new drugs in interstitial lung disease. Now, what we're doing with all these resources is we're generating large amounts of data, and we need to accumulate that data, and we need to share it. And we had several presentations, including from Pierre Delsoux, who's from DG Santé in the European Health Union, telling us the large amount of work that's being done to share data across borders, how this can be done safely, how your data is used appropriately, and that particular amounts of data, metadata, or other personal data may actually stop at the border of your country, but other data can be shared. And this goes for a whole range of measures, including the registries that many of us are involved with. We had quite a few presentations too on artificial intelligence, and there's lots to be said for it. In terms of reducing human error, we have even larger amounts of information that we can gain insights from, develop prognostic indicators, and decision aids. But as was also pointed out, as well as augmenting decision making, it's really important. We had a presentation on retaining the human in the loop. so that humans are really part of this process and not being excluded from it, so that we're augmenting human decision making and having a number of advantages in that we can do things such as save time, and also a number of very simple things that AI is great at. For example, looking at a CT scan, there is information on that scan which is below the resolution of the human eye, and so no radiologist is going to identify it, but these tools can do, and therefore it's a perfect example of a great advantage. But there are problems too. And so we need to scrutinize it all in detail. Another nice example, which is related to us in pulmonary medicine, and I have sort of mixed views about it, but we have to take it as true. And this is looking at the interpretation of pulmonary function tests. And here, AI interpretation of pulmonary function tests, so going into a pulmonary function lab, doing your lung function, was better, and there was more agreement with the results of using an AI model than pulmonary physicians. And we have to accept that if that's the case. There's plenty of scope too for teaching and educating our healthcare professionals, and this is an example of an ERS simulator which has been devised for trainees when they're learning about setting up ventilators, for example, for acute exacerbations of COPD. And we're using the advantages of Zoom and all sorts of other methods, as Kel pointed out, for communication, and we're not going to stop doing that. The good thing about the summit is that digital health is popular, and we had the highest ever interest in terms of registration in any event we've had bar the Congress. So that's encouraging. And my summary is here. So where are we now? I think, as you saw from that consultation we've all experienced, that there has been a change between the relationship of healthcare providers and individuals themselves, the individual patient themselves, and we have to work to improve that. There are challenges, as we've said, with AI, with data sharing, with barriers to technology, but there's a lot to be excited about. For example, just one brief example, it is now possible for someone completely inexperienced with ultrasound to use an ultrasound probe, whether it's in a GP practice or whether it's out in the wilds of the outback in Australia, apply that ultrasound probe to the chest of a patient, whether it's examining their heart or examining their lung fields, to be directed of where to take that probe and the measurements to get, for AI to interpret that information and send it on to a pulmonary expert, for example, or a cardiologist, who will then diagnose perhaps a pneumonia or a pleural effusion or a valvular lesion. And this can be done, and so spreading the applicability of those techniques to places where it's never possible before. The way forward is working together. We have to design these products together so everyone gets the best of them. We have to make sure that there are options, virtual and digital options too, and be careful not to stop providing personalized care. We've talked about digital exclusion barriers, which I suspect you will discuss further. But I think my main take home from this is we should stop othering digital care. It's not exceptional. It's something we do every day, and it should be evaluated and incorporated in care pathways, just like we do any other treatment or intervention. And I think that's important for the future. So thank you very much for listening.